girl
دكتورة دعاء دكتورة
presented
دعاء
صباح الخير
with
أستاذ.
headache.
صباح الخير. حتى تحكي لنا على الكيس بابا، تفضلي.
إن شاء الله.
نعم أستاذ، هي 7 years old girl present with headache and vomiting.
headache and vomiting 7 years.
تمام.
هذا T2
تمام.
T1 flare.
هي الهيستوري اللي انطته مال هيديك هي ريزين صحيح؟
نعم أستاذ.
مالت ريز انتراكرينيال بريشر.
أي بالضبط، يعني
الهيستوري
vomiting وهيك. دكتورة عندك ساجيتال؟
ساجيتال لا ما عندي، بس أنطيتش الدوي بالADC وعندي فوت كونتراست.
تمام.
بس هو الساجيتال is very
هو
important.
أي بالدفون كان موجود.
إيه.
هذا T1 فوت كونتراست. المفروض نفتح
هذا دعاء شفت يعني.
دكتور هو يعني multiple axial section MRI of the brain for a child 7 years old. أكو infratentorial mass lesion seen بال يعني posterior fossa. Rounded heterogeneous seen mainly أنا دا أحسها within the ventricle, within the fourth ventricle.
Yeah.
Slightly well defined بس heterogeneous. بس إذا ممكن دكتورة بس ترجعين للT2 بس أتأكد من signal intensity.
أي تمام. عندي صورة أستاذ يعني سيتي، لأن هو كان عندها فيلم مسويته بغير مستشفى، فإذا تحب أعرضها قبل لا تعلق دكتورة دعاء.
هي تريده لو تحتاجي دعاء؟
دكتور يعني هي ممكن أكيد تفيدنا براحتك. تريد نكمل نشوف الديفرنشال وبعدين نشوف صورة السيتي؟
السيتي شوفي لنا MRI
أوكي.
وقلنا فد your opinion your hand، وإذا هاي نروح على السيتي مو فد مشكلة.
نعم.
هو السيتي ايش راح يضيف لك؟ اكو كالسيفيكيشن لا ما؟
بالضبط. فهو يعني there is a rounded relatively well defined mass lesion seen within the fourth ventricle, heterogeneous signal intensity mainly hypo to iso on T2, heterogeneous signal intensity on T1 with شفت small hyperintense foci بال T1 بالفلare heterogeneous also hypo and hyper signal intensity. بالديفيوجن كأنه شفت فد small component showing restricted diffusion. The ventricles, the lateral ventricles and front ventricle weren't dilated, surprisingly. ما حسيت اكو فد significant hydrocephalus.
You're right.
So we are dealing with the posterior fossa mass lesion in a child. يعني اللي talk to differential diagnosis بالنسبة لي والmost common اللي يجون هم child وهم posterior fossa هم الميدولوبلاستوما والإبندايموما.
Excellent. Okay.
الديفرنشيشن بيناتهم يعني الساجيتال ممكن كان يفيدنا كلش لأنه شوية الإبندايموما تميل إنه
بعد غير
تدخل للفورامينا. البلوينج السوي
وبعد
ممكن يفيدنا. الديفيوجن اكيد لانه الميدولوبلاستوما المفروض تكون ريستريكتد كلش. هو هايلي سيلولر تيومر يعني المفروض الديفيوجن يفيدنا كريستريكشن، والسوي ممكن يفيدنا كهيموريج على اعتبار الابندايموما يعني اكثر يصير بها هيموريج. والسي تي ممكن يفيدنا ككالسيفيكيشن لان هم مور كمان انه يصير الابندايموما بها كالسيفيكيشن although الميدولوبلاستوما هم يصير بها كالسيفيكيشن.
بس الابندايموما الكاركترستكس مالتها اكو كاركترستيك فايندينج اوف ابندايموما.
هي الكاركترستيك مالتها انه تدخل انه تطلع من ال floor of the foreventricle
floor
وتمشي بالفورامينا، تطلع من الفورامينا أو فلوشكا أو أوف ماجنيني يعني تنزل. الميدولوبلاستوما راحت من بالي insinuating هي بس الاسم راح من بالي.
التسمية. أوكي إذا شو اسمه أنت خليتي ميدولوبلاستوما لو الإبندايموما طبعا intraventricular differential diagnosis. شكرا دكتورة دعاء. نروح على الدكتور رافد.
السلام عليكم أستاذ.
هلا شلونك شلون؟ Your opinion رافد.
والله مثل ما قال الدكتور دعاء we are dealing with intraventricular يعني fourth ventricle mass يعني child فاكو limitation بالديفرنشال diagnosis اللي هو ميدولوبلاستوما ممكن نخليها والابندايموما والكورايدال بلكسس ممكن نخلي بابيلوما او كارسينوما. بس وجود الريستريكشن دكتور يخلينا يعني انه limitation بالدايجنوزس يعني تمشي باتجاه الميدولوبلاستوما لانها الوحيده اللي هايبر سيلولر وتسوي لنا ريستريكشن.
صحيح. شكرا دكتور ميثم.
نعم أستاذ السلام عليكم.
عليكم السلام. Your opinion ميثم.
نعم أستاذ والله يعني هو مثل ما قالوا الزملاء هي فعلا يعني fourth ventricle mass lesion ويعني أكو بها وإن كان partial restriction يعني يمشي.
You are right هي intraventricular mass. تسمعني ميثم؟ الو ميثم. دكتورة هند عبيد.
نعم أستاذ صباح الخير.
صباح الخيرات.
نعم أستاذ.
What is against one of the differential diagnoses اللي ذكروها انه لتكون كرويدوبلكسس بابيلوما.
كرويدوبلكسس بابيلوما انه دكتور
شنو اللي against تبع الكيس؟
انه هي بالفورث فنتركل هي اكثر شيء مست كمان باللاترال فنتركل.
هاي واحد بعد هذا الكيس شنو؟ against كرويدوبلكسس بابيلوما.
يعني
هذا الكيس
يعني أنا شفتها إنه لأنه بهذا الفنتركل لأنه بالفورث إحنا عادة تجي ولأنه ريستريكتد.
بس اسمحي لي ممكن تجي بالفورث فنتركل لو مو ممكن
هي ممكن تجي بس هي الماست كمان بس هي الماست كمان إنه تكون باللاترال فنتركل ولأنه يعني الفنتركلز نورمال not dilated.
excellent
أي لأنه
no associated hydrocephalus. هذه very good important point against الكرويدوبلكسس بابيلوما لأنه عادة الكرويدوبلكسس بابيلوما شو يصير وياها؟
تكون production مع CSF over production CSF.
absence of كيفالس هذه against البابيلوما of the corona. Excellent. شكرا دكتور.
شكرا دكتور.
منو بعد يحب يضيف شيء قبل ما نروح على السي تي؟ معكم.
السلام عليكم استاذ، ممكن اضافه؟
عليكم السلام. منو؟
بالنسبه للبوستيريور فورس ماس، يعني انا المفروض اسوي ايمجينج للهول سباين، يعني اكو ريسك اوف ليبتومينينجيال انهانسمنت، واللي يبين كانه شوجر كوتينج above the surface of the spinal cord. يعني مهم بالنسبه لكيسات الميدولوبلاستوما بالابندايموما اشوف ليبتومينينجيال انهانسمنت. واعتقد اكو اضافه ثانيه، اعتقد الكيس هم اكو بها اراكنويد سيست بالتمبرال ريجن، اعتقد يعني
اكو بالليفت يمكن
بالليفت.
صحيح.
شكرا لحضرتك.
موجود. شكرا لك. شكرا دكتور رفع المو.
بل استاذ.
شكرا جزيلا دكتور رفع.
شكرا جزيلا لحضرتك.
for the important addition بالنسبه لها انه once you find مثلا posterior fossa tumor particularly in the pediatric age group, you have to go for the MRI of the spine to exclude any seedling or metastasis لانه اكو قسم من التيومر تصيرها. شكرا جزيلا. اذا دكتوره سرى عباس،
نعم
نروح على السي تي سوي ستوب شير للام ار اي. صحيح همين دارج هذا كلش واضح الاركنويسيس بالليفت تمبرال فوسا.
أستاذ هذا السيتي إنه هي كانت كلش الكيس مثل ما قالوا الزملاء إنه هي تمشي ويا الميدولوبلاستوما، وبالسيتي كانت هي السيتي مسويتها إن أنذر هوسبيتال، فإنه هذا الهايبر دنس أبيرنس هو كلش كاركترستيك للميدولوبلاستوما.
اكسلنت. صحيح. يو ار رايت. عندك مسوية توك؟
نعم أستاذ نعم.
Medulloblastomas
are the most common malignant brain tumors of childhood. They most commonly present as midline masses in the roof of the fourth ventricle with associated mass effect and hydrocephalus. Although medulloblastomas has been classically thought of as a single entity, it is becoming increasingly evident that there are a number of distinct molecular subgroups with overlapping clinical, histological, and imaging features. The four molecular subgroups currently recognized by the WHO classification have been named WNT, SHH, Group 3, and Group 4. Perhaps what most of us think of as a typical medulloblastoma, which is a midline tumor in early childhood, is a Group 4. Genomic classification, WNT, which is the least common subgroup, accounts for 11% of all medulloblastomas. It occur in children and adults and not seen in infancy, with male to female ratio is about 1:1. The second type is SHH, which contain SHH receptor and mutation may be associated with Gorlin syndrome. It's seen in infant and adult and is rare in children, with male to female ratio is about 1:1. Group 3 account for 27% of all medulloblastomas. It affects infants and children and rare in adults. And the male incidence is more than female. Group 4, which is the most common subgroup, accounts for 34% of all medulloblastoma, typically occur in children and is rare in infants, with male to female ratio about 2:1. WHO classification of medulloblastoma, the tumors in general tend to be extremely cellular and are an example of a small round blue cell tumor, which results in unpredictable imaging features. They are categorized as CNS primitive neuroectodermal tumor, WHO grade 4. The types according the WHO classification is based on the histopathological finding and classified as classic, desmoblastic, extensively nodular with neuronal differentiation, large cell and anaplastic types. Epidemiology, overall medulloblastoma accounts for 12 to 25% of all pediatric CNS tumors and 30 to 40% of all pediatric posterior fossa tumors. They are also seen in adults. but only account for 0.4 to 1% of adult brain tumors. Taken as a group, there is a moderate male predilection with male to female ratio about 2 to 1, although this is only true for group 3 and group 4 tumors. They usually present in childhood, with 77% of these cases before the age of 19. The median age of diagnosis is 9 years. When diagnosed in adulthood, they typically present in the 3rd and 4th decades and are more likely to arise in atypical location with better prognosis. Importantly, the age of presentation and gender ratio is influenced by the tumor genomics. Association. Medulloblastoma are associated with a number of syndromes, including Coffin-Siris syndrome, Cowden syndrome, Gardner syndrome, Gorlin syndrome, Neef-Romani syndrome, Turcot, and hydroxyglutaric aciduria. Clinical presentation. The growth of these very cellular tumor is often rapid and accounts for their relative rapid clinical onset. Typically, presentation occur over a few weeks with features that are dominant by symptoms of raised intracranial pressure as a result of obstructive hydrocephalus. In approximately 40% of patients, there is evidence of CSF seeding at the time of diagnosis. The radiological features overall, the vast majority, 94% of medulloblastoma arise in the cerebellum, and the majority of these from the vermis, about 70%. They tend to protrude into the 4th ventricle from its roof and may even grow directly into the brain stem. This pattern is particularly common in group 3 and group 4 and in some SHH subgroup tumors. Other areas are less common and are seen more frequently in older children and adults. In such cases, the tumor is also more likely to be poorly marginated and demonstrate larger cyst formation. Adult medulloblastoma are usually located laterally in the cerebellar hemisphere, with only 28% centered in the vermis. These are most commonly of the SHH subgroup. Cerebellar peduncle epicenter is almost exclusively seen in the relatively indolent WNT subgroup. CT. On CT, medulloblastoma often appear as a mass arising from the vermis, resulting in effacement of the 4th ventricle and basal cistern and obstructive hydrocephalus. They can also occur more laterally in the cerebellum. They are usually hyperdense in 90%, with cyst formation or necrosis are common in 40 to 50%, especially in older patients. Classification is seen in about 10 to 20% of cases. Enhancement is present in over 90% of cases and usually prominent. This is a CT scan axial image of 5 years old girl show large, high density posterior fossa mass with obstructive hydrocephalus. On MRI by T1 sequence, it is hypointense to the gray matter. In T1 with contrast, overall 90% enhance, often heterogeneously. Group 4 tumors tend to enhance less. By T2 flare, overall are iso to hyper to the gray matter, heterogeneous due to calcification, necrosis, and cyst formation, with surrounding edema also common. By Dewey and ADC imaging, high diffusion weighted signal, restricted diffusion, and low ADC values. MR spectroscopy show elevated choline and decrease in acetyl aspartate. This is an MRI axial images of a child, T1 and T1 post-contrast, and Dewey, there is a posterior fossa mass located posterior in the posterior 4th ventricle arising from the vermis, has prominent restricted diffusion and show heterogeneous enhancement. This is another case, an adult which have atypical location and atypical appearance. This is a 35 years old female, and this CT of the brain axial image show mixed solid and cystic mass surrounded by peritumoral edema within the left cerebellar hemisphere. The solid component appears slightly hyperdense. This is another MRI, axial Dewey and T1 post-contrast MRI demonstrate a mass in the left cerebellum hemisphere of the same patient is composed of mixed solid and cystic components with the peritumoral edema. The solid component demonstrates restricted diffusion on dewy and avid contrast enhancement and of the solid component post-contrast administration. The treatment and the prognosis typically consist of surgical resection, radiation therapy, and chemotherapy. In general, the tumor are quite radiosensitive. Cerebellar mutism syndrome may occur after surgical resection of medulloblastoma. The prognosis is most strongly influenced by the molecular subtype. WNT have a very good prognosis. SHH subtype in infant is good, while in other age group is intermediate. Group 3 is poor prognosis, while group 4, which is the most common type, have intermediate prognosis. The prognosis also is considered poor if we have young age at the diagnosis less than 3 years of age, or we have incomplete surgical resection, or in the presence of CSF metastasis at the time of diagnosis, which is most common in infants and children and usually uncommon in adults. Histological features also have an effect on the prognosis, and desmoplastic and nodular histology having a better outlook than large cell or anaplastic histological features. The expression of HER2 new oncogene is useful in the staging of medulloblastoma. If we have no CSF metastasis and complete surgical resection, negative this gene expression, the 5-year survival is about 100%. If we have no CSF metastasis and we have complete surgical resection, but we have positive this oncogene expression, the 5-year survival drop to 54%. CSF metastasis and or incomplete surgical resection, the 5-year survival is about 20%. Differential diagnosis. In pediatric population, we consider alternative diagnosis such as epidymoma, usually arises from the floor of the fourth ventricle and typically squeezes through the foramen of Luschke and doesn't usually cause much diffusion restriction. This is an MRI of epidymoma in older age group. We have large intraventricular mass in the fourth ventricle extending bilaterally into the foramen of Luschke. Second differential diagnosis, we have atypical teratoid rhabdoid tumor, which is affects very young children and usually aggressive. This is the appearance of this tumor. We have midline vermis-centered posterior fossa tumor bulging into the fourth ventricle with obstructive hydrocephalus, hemorrhage within the occipital horn of the lateral ventricle, not shown in these images, have been found. The tumor is heterogeneous with cystic CSF-like densities, and component of hemorrhage is also seen. The third differential diagnosis is pilocytic astrocytoma and usually have a large cystic component and enhancing nodule, as we seen in this sagittal MRI of a child brain with post-contrast T1 sequence, large posterior fossa cystic mass with enhancing posterior nodule, neural nodule. The fourth differential is brainstem glioma, which may be exophytic or diffuse. This is two images show diffuse enlargement of the pontine by enhancing mass, by hyperintense mass in T2, marked expansion of the brainstem appearing centered in the medulla, elevating the pons and effacing the fourth ventricle. And we have exophytic type with this T2 MRI, which show well circumscribed dorsally, exophytic brainstem mass centered in the medulla oblongata. The fifth differential diagnosis in children is choroidal plexus papilloma. However, it is more common in the lateral ventricle and associated with hydrocephalus. In adult population, we should consider cerebellar metastasis, hemangioblastoma, choroidal plexus papilloma, and epidymoma. This is the reference. Thank you.